I invite Dr. Shaji Hussain, cornea consultant, Al Salama Eye Hospital, Perinthalmanna, for his talk on Pearls for a General Ophthalmologist.
Morning everyone. Morning everyone. So this will be the last talk of the IC, and as you can see, this is a presentation basically on how to manage a patient just before his keratoplasty and how to co-manage a patient who has undergone keratoplasty. Keratoplasty and how to co-manage patient after keratoplasty, and this is not intended for corneal surgeons, but this is for you. So which are the cases we have to keep in mind when this topic comes in? It can be corneal dystrophies, corneal infections, PBK, keratoconus, traumatic corneas, and post-PKP patients. So am I qualified to take care of these corneal conditions? Is the first question that will come to your mind. And when you see a patient who's undergone keratoplasty, should I just refer these corneal conditions? Well, the answer to that is yes, you are ready, you will be ready after the presentation, and it's best to handle the patients initially and don't refer them in the next moment. So to start up with the primary corneal care and the managing of keratoplasty patients, indications are: when do we do keratoplasty? Keratoconus, PBK, stromal dystrophies, fuchs endothelial dystrophy. And these cases we do a optical keratoplasty. And the next in line is tectonic, that is when you have a defect in a part of the cornea, when you patch it up and maintain the contour of the eye, you call it as tectonic. And finally, when you have traumatic corneal opacities and infective cases, you call it as a therapeutic keratoplasty. To start up with, when to do keratoplasty in a patient with keratoconus is when the PAC is too low and less than 350. And in this case, the vision was counting fingers. He underwent keratoplasty. This was acute hydrops, managed and healed with the corneal opacity, and he landed up with a good vision after keratoplasty to 6/9 with a -2 cylinder. Patient with PBK, again, when he is having severe pain, vision is affected, he can't no longer manage. This patient had a vision of counting fingers, went ahead with penetrating keratoplasty, landed up with a vision of 6/60 in spite of having a good clear cornea. Why? Did an OCT, there was a problem in the retina. Went ahead, next case, stromal dystrophy. When do you go ahead? When the vision is too poor and when the vision is affected, we are going ahead and the vision maintained at 6/18 here with a -1. Fuchs endothelial dystrophy, when the vision is affected, photophobia, we go ahead and do, cases were discussed very well. Traumatic corneal opacity, a patient with corneal opacity, when IOL was placed, in spite of that vision did not improve, went ahead, did a keratoplasty. Next, infective cases, well managed by Sanjana. So here the dictum would be, first save the patient, save the eye, then think about the vision. And we do it when it is proceeding and almost reaching up to the limbus. We'll try to manage it medically initially. Then when not to do keratoplasty, in a case of keratoconus, when the PAC is adequate, what do? We manage by doing a C3R. PBK, when the patient is having pain and vision is not a concern for him, then we do go ahead and do a conjunctival coating for that patient. And in stromal dystrophies, when the vision is adequately much better than 6/18 with a clear center and the patient is also not complaining too much, we'll just hold on. Fuchs endothelial dystrophy, when it can be managed with drugs for his symptoms, we can go ahead and continue managing it, but when it gets worse with a pain, a photophobia, then we can think about DSEC, otherwise we can manage with sodium chloride. Traumatic corneal opacity, when the opacities are restricted to the periphery and minimal astigmatism has to be managed with glasses, and the peripheral opacities need not be taken care of. Bacterial infections, if there is an adequate response to drugs and you are seeing a promising staining later on with the management, you need not go ahead with the therapeutic. So to summarize with the cases, penetrating lamellar, anyway in therapeutic you can only do a penetrating keratoplasty. The other conditions, now when do we think about anterior lamellar is when the condition is restricted to the stroma, we think about stromal, that is dull. When the condition is restricted to the endothelium, we think about doing a DSEC. So if you are a starter, you can always restrict yourself to penetrating. If you have crossed your 100 cases of penetrating, then you can think about going for a lamella. It's just like before you start your phaco, you should be having a good hand input SICS, no longer taken now, but still that's how you can plan your keratoplastics. How do we manage a patient? Now let's say a patient who has already undergone keratoplasty has come to you, and there are certain complications that you can look at and manage confidently. Now this case was a patient who had an infective opacity, vision was very good, 612 maintained with a -3 cylinder, but 1 year later he came up with a hand movement vision. What was wrong here was, the IOP was seen and it was 50, CD was 0.8. He was continuing his steroids for every red eye, every discomfort he had with his eye, and finally landed up with a vision loss because of IOP, in spite of having a very good graft after post PK. This is the post operative case. So this here the villain was steroid. So when a patient comes to you, make sure is he on steroids, how many months has it been. So usually we stop it by the 6th month, tapering it gradually, and if the patient is faking, there is a higher risk of IOP, but if it's pseudo faking, there is lesser chances. We may even continue 1 time a day for a year as well. So it depends on whether the patient is faking or pseudo faking. Now suture related, as you can see, there is a loose suture, so the vessels are getting attracted here, so that is not a good sign. You have to think on that side also. So here you will have to go ahead, because this can take you up to rejections and infections. So the advice here is to remove it. Usually we can remove it after the 4th month. Maybe we keep it also because it's an assurity, like in spite of any traumas, if the sutures are there, it can hold on. Maybe when it gets disintegrated, you can remove it later, but there is no harm in removing it after 4 months. Continuous sutures, again there is a challenge. We can usually remove it after the 5th month, but the problem is when you have these kind of scenarios wherein you can't just remove these sutures. You will have to, since it's a continuous suture, you will have to go ahead and remove the entire suture later on when there is an infection. So here suture related infections are usually bacterial, and it is by streptococcus. So here and here with streptococcus we usually manage by giving fortified ceftazidime or cefazolin. If it is a reinfection by a viral, now this is a big dilemma, like we'll have to manage. Usually when you have a simple opacity and you have done a PK and this is how the patient lands up, this is viral. Now here you will have to manage with the costlier anti-viral agents like ancyclovir systemically and valcyclovir. Now here if you see, you have a cornea post PK, this area is clear, that area is hazy. So you may be looking at a case of rejection. The clarity is gone on that side, and there are KPs also present. So all that is telling you, you may be looking at a case of rejection. That is when you will have to start the patient on steroids. Now here graft failure means this is a point of no return. You will have to think about doing a repeat PK. Maybe after this has settled down, we can wait for 3 months and then go ahead and do a repeat PK. Here the conjunctiva seems to be quiet, so things have started settling down, wherein you can think about doing a repeat graft later. So with that, I'm ending my talk. Can all the speakers come in? We can have a small discussion. Point ups.